What's up, everyone? Welcome to the CPTJ podcast. I'm one of your hosts, Blaze Robson, and with me I have the awesome Ashley Bergeron. So, for today's guests, we have Deborah Slay, who has a great taste in outcome measures, Haley Bento, who has great taste in cardiac earring jewelry, and we got Max Hunter, not to give a bit of a spoiler, but has a pretty decent collection of Hawaiian shirts himself. So, what they did is they took that question, put together two groundbreaking studies and made up this clamshell protocol. And this interview is great because it has a great blend of not only interactions between other disciplines, how to get moving forward, trying to break, tradition, some would say, uh, how the academic world merges with anecdotal experience and what you kind of do with that moving forward, and how that can be pretty convincing for a lot of folks too. Uh, it's also filled with real world challenges, so adherence by some patients, adherence between everyone and the clinical team. But I think our three guests do a great job of putting everything together, making it digestible, and hopefully giving you all some tips and tricks on how, if you want to do something similar to this, implementing one yourself. Let's get into it.
So this project originally originated, yep, from Deb's project as a resident. So how does it feel to actually like have this published, completed, like from your residency days? This is legit, this is out there.
Honestly, I feel like it's kind of surreal, but also just so exciting. And honestly, I just feel an overwhelming sense of like gratitude that it got put out there. Just because not only was this such an area of literature that's lacking, but also just having the support to push it through the finish line, even after my time at Utah in residency doing clinical work was over. Just the support that I have, like Haley, like getting a grant so that we could finish this, Max, like continuing to do all of these outcome assessments on all of these patients. It just feels so good to like get it out there for the patients and just all the people who supported me to like get this off the ground. So yeah, just really good.
Amazing. And what originally sparked this idea? Because I know in residency there's so many different project ideas probably flow in. Was that already like kind of on the ground, or did you come up with it?
No, I came up with it. I will say, like, so Brian, one of the clinicians at Utah, they had just recently rolled out move in the tube precautions for sternal precautions. So I do think that like it kind of went hand in hand with that, just in terms of like the fact that it really was on the forefront of my mind. I also went into residency with a couple years of experience, and I loved the lung transplant population. And one thing that I found really interesting with my time in like with my time there and then my time with Utah and specifically in the pulmonary rehab department is just the wide discrepancy that I saw in clamshell precautions. The first place that I was at, they weren't allowed to use their upper extremities at all. And then I saw in pulmonary rehab, they really were only doing aerobic activities and they weren't doing any upper extremity exercises or anything like that. And just knowing what I know about the clamshell incision itself and just how these lung transplant patients recovered, I really just wanted to like dive in a little bit more. And then once I looked at the literature, I saw that there like was none really. And so it just kind of like birthed like, okay, well, let's try to put something out there because I'll never have more time than I have right now and more support. So let's do it.
Okay.
One thing that I found fascinating. So, admittedly, I did not know what a clamshell procedure was at all. So, the hospital system that I'm in my residency for, we don't do any lung transplants. So, whenever Ashley was like, "Okay, here's the schedule, and like this is the article, and this is what's going on," and I Googled it, I thought it was something out of like an Alien versus Predator movie, because I was like, I mean, you think like just a sternotomy, like a chest burster and all that stuff, but it is crazy.
Yeah,
I
it's
feel like it looks like way more. It looks like way more trauma than it actually is compared to a sternotomy. Is that right for me to
yes,
think?
It's
you're
pretty dramatic.
100
Yeah.
right.
Sometimes we'll explain to patients like they're gonna, cut you from all the way across the front of your chest and pop your rib cage open like the hood of a car,
Mm.
right? That's kind of a good visual of like how they're gonna open up to access those lungs to replace them. And it is more invasive. And if you think about, even your own body and how many nerve endings you have in those areas and how sensitive that skin and those tissues can be, it can be extremely painful for patients to have that. More so, I think, than a median sternotomy. Not having had either myself,
Yeah.
but
Fingers
Blaze, I
closed for
also
you.
think it was one of those things that we really considered. I got to watch Deb's brainstorming process as she was thinking about what's involved in this protocol, and she had the opportunity to go observe one of these surgeries. She could see the clamshell incision, see the whole surgery all the way through, and then came out of it just like exploding with ideas about what can we do, and bounced it off of all of these experts around her before she went to present it to the surgeons. And it was super impressive to just kind of see all of the considerations that were going into that for her.
And it's more than just a lung transplant, right? You can I was reading more, you can do these for lung and heart transplants too, or just singling them out, right?
So usually it's done for bilateral lung transplants, and then you can do heart and lung simultaneously. They're going to do clamshell access. Some surgeons also for bilateral lungs, they might do what's called bilateral anterior thoracotomies, which is basically when they spare the transection of the sternum. But for the most part, it can be used for this. And then sometimes also clamshell can be used for like trauma cases, which we did not see a lot of and was not included in the study, but you can see it in those cases too.
Oh, it's so neat. Oh, it's so cool. Learn.
Do you guys do robotic lung transplants as well at View View?
No, currently none of our surgeons do a robotic assisted lung transplant. They will do some other thoracic surgeries, but lung transplant is not one of them at the moment.
Okay, gotcha. All right. So Max, were you also a resident whenever Deb was one?
Yes,
Okay.
and don't tell the acute care academy that I'm on this podcast because I was the acute care resident the year that Deb was our cardiopulmonary resident. So we got to bounce ideas off of each other with slightly different lenses.
Okay, well, I won't say anything. Secret safe with us and whoever's listening to this. So
Good.
whoever's listening, don't say anything. Oh, wow. Okay, so that's wonderful that you guys got to collaborate. And Deb, did you go to the surgeons yourself and go like chat about this, or did you get like a team? Like how did you approach it?
It was definitely a team of us. That was one of the things that I loved about residency. Haley was really helpful in this process, and then Max was also a part of the team. Brian was a part of the team. So it was really my idea, but it would not have taken off without all of the people that I had kind of around me helping, and even the people who I consulted. Like I talked to people from IU and their COLT program, and Duke and their pulmonary rehab. So, but yeah, it was a team of us. Haley kind of helped guide me with who I needed to talk to and securing all of the necessary stakeholders. Because when you enter a hospital system, you don't know people yet. So having people who like know and have those connections is super important.
Yeah, and that's one of the best things I think about being in a residency program is you're connected with these mentors, but it's not just them you have access to, right? It's like your mentors know all sorts of people throughout the healthcare system in different areas that you can get connected to. And it was like, oh, you have an idea? Let me help you run with this idea because you deserve that opportunity as a resident, and we have the resources and the knowledge and support to do that here. That's a really special thing about being in a healthcare system that's built around learning, and being in a residency program where you're an N of one and you have all these mentors, doing whatever they can to make sure that your career is successful. And whether that's, pushing forward a project that you started through its completion over 4 years. Has it been 4 years?
I think so. It was like 2022 when I finished
Okay.
residency. So yeah.
Three and a half years later, because these things don't happen quickly, they take time. But it's a pretty special place to be, I think, as a resident and as a residency director and a mentor. That's one of the things I love most about having residents is being able to catch on to their fire, their ideas that they have, and helping them run with it.
And so that it brings a really good question to mind for me because you talk about collaboration and finding the folks within the hospital system to get you, into the OR, to talk to the right people to have these experiences. Whenever you were writing and developing this protocol, did you have any pushback from other professions or disciplines? Like, for example, now within the hospital system I'm at for my residency, we're trying to revamp what it means to have sternal precautions. So being a bit more liberating for the patients rather than, all right, don't use your arms because you might have some surgeons that haven't really read the literature or having a little bit of inertia trying to adapt this new way to move via sternotomy. Did you find that at all whenever you were trying to do this kind of research at all with the clamshell protocols, uh, by chance?
Honestly, we got pretty lucky, which I was surprised by. We kind of brought it to, at the time, the primary lung transplant surgeon was Dr. Stringham, and he was on board from the jump. Like he was actually super grateful about the fact that like we were putting this in place and kind of looking at it. So we did not have a lot of pushback for this. We had a lot of support, which was really nice. I think that sometimes like you have other stakeholders who, like this was a protocol that we kind of put on across like ICU, acute care, pulmonary rehab. And so I think sometimes you have stakeholders within that where and I feel like Max did a really good job of this, so he can kind of speak to it a little bit more. But sometimes you have people who like don't understand why you're doing what you're doing, and you need to help facilitate a little bit of buy-in.
I think that's an awesome question, Blaze, because it's really a good way to illustrate like what are the barriers to actually making change. And I think one of the cool things here is that this is physical therapist driven change, which those are some of the coolest changes that I think exist in healthcare systems because we just view things so differently. And just like Deb said, from our physician group, we got fantastic support even after Deb left, and we went from 12 lung transplants in Deb's year to 36 the year after, and we're on track for 50 this year. And
Wow.
I've been trying to like keep this momentum going. We get fantastic support from our physicians for all the physical therapy implementation. The biggest place that we had the most pushback was interestingly from our pulmonary rehab, which is not run by physical therapists. And so I don't think they have that same perspective. And it's just another awesome reason why PT can and should be much more involved in pulm rehab.
So was your pulmonary rehab kind of similar to like a cardiac rehab where it's like you bike and then you walk and then maybe you do another mode and that was like what they were doing? Okay. So there was no like strength training protocol in it or like stretching. And so you guys ended up adding that in. Okay.
Because they had all the equipment there. They just didn't really use it.
When we were implementing this as well, I think that they were coming out of some post-COVID, or I guess still in COVID restrictions with how many patients could be in the gym and how long they could be there. So patients were very limited in the time they were allowed to be there. I think at one point they were only allowed to have 4 patients in the gym at once.
Wow.
And
Okay.
so they were getting them in there to do the aerobic exercise, which required a little bit more supervision, and then they were kicking them out, to make room for other patients, which is understandable given the circumstances. But I think that some of the practice of allowing patients to stay and work through an entire fully rounded exercise routine had kind of gone away at that point. And I think that's probably the case in a lot of clinics where things like that happened during the pandemic, and we maybe haven't yet returned to pre-pandemic quality levels.
Okay. And did you guys have like another facility that you based off the strength training protocols, or did you like come up with it yourself? Like what was your inspiration for that? Because I kind of read through it and it seems like it's pretty comprehensive.
That was kind of so there was a really good article that was done by Louise M. Fuller that had a lot of, I think I drew some of that inspiration from. I also spoke directly to like Kristen DePerna and Lindsay Tucker at IU for their COLT program, which is really good. It's basically like a PT run intensive pulmonary rehab. And then also I talked to Rebecca Bird at Duke Pulmonary Rehab. Also, a lot of that protocol was like based off of like, like the book on pulmonary rehab and just how you structure exercise. But yeah, I think that the insight of those clinicians was extremely helpful just in putting it all together. So.
Okay. And whenever I was reading through the protocol, just to clarify, did the precautions, like the 4 weeks, start after they were discharged from the ICU? So then whatever time they were in the ICU, that time isn't really counted, but like the day they leave, that's the 4 weeks on.
So the precautions were based off of timeline was based off the date of the surgery. And then as
Okay.
far as like the week of like kind of the exercise program, that was based off of when they went from the ICU to the floor. That was usually when it was initiated. And then sometimes, depending on where the patient was at and how they were doing, they would like either continue in pulmonary rehab or they would sometimes just end up like starting over and then kind of doing it just based off, you work in the hospital systems. You kind of know sometimes you're able to do all of the things and sometimes you're not. So.
Because of like the results that you had, and we always agree as therapists that more mobility, for the most part, is preferred and it's better. Are there any other precautions that you kind of looked at, like maybe we're a little bit too stringent on these because the clamshells seem to do really well, and then we're learning about moving the tube and beyond. So, do you have any ideas going past this protocol?
Yeah, I mean, I'm trying to think, right? A lot of the precautions, especially in the acute care world, like you might get non-weight-bearing precautions that are based on the healing properties of bone. Those are pretty
Yeah.
standard wherever you go. So other precautions you might look at would be something like a C-section incision or an abdominal incision, things like that that happen pretty commonly that do we have research about what happens if we liberate precautions a little bit more? I
Mhm.
don't think we have studies in a lot of these other areas. I think C-section is one of those where PTs are moving into that area of providing more standardized PT evaluation and care following a C-section because it's the most common abdominal surgery in the world, right?
Oh
And
yeah.
Mhm.
PT have historically just been left out of that conversation. But it's a major abdominal surgery, and what are the precautions we're giving? Are they reasonable,
Mhm.
given that this person that had that is likely a new mother and maybe has other children at home that they have to manage as well, and are going home, right? Like what is reasonable, what is functional for people, and I think that, like Max said, that's where our thinking about the whole person in the recovery process and the return to function, not
Mhm.
just survival and infection rates, can be really helpful. So, Deb thought thoroughly about clamshell incision, but I think that we should encourage PTs out there that work with different kinds of incisions, different kinds of surgeries to be thinking about that.
Yeah, the genesis for the question really comes from just my experience so far with just the article that you all put together. Because again, I'm in a residency. I've never heard of a clamshell. And who knows what new advances and like surgeries that you might have. Like I've seen LVAD stuff with bilateral thoracotomies, and that was really neat and new that I got to hear about. So I'm just very curious to see, what outside of just, chest incisions or like the upper thoracic. Yeah, I'm just a baby PT, just a very, very curious baby PT.
Yeah, I mean, I'll give another quick example of that. We had, in the past 5 years or so, our healthcare system has started doing gender affirming care surgeries, and I know Max is an acute care resident, got to work with that team and some of those patients, and the physical and occupational therapists were really instrumental in helping develop the protocols for recovery and how much sitting, how much activity, what kind of movement is allowed after those surgeries, and that's something that I think we as a profession should be really proud of. Like when new advances in surgery are happening, we need to make sure that we have a seat at the table and are part of developing those protocols from the get-go.
And what do we do to get our seat at that table? Because I love collaborating with other disciplines, but sometimes you just have folks who are a little bit resistant or reluctant at first to try doing some more, I'll just say liberating movements with a procedure. But what does it take for us as therapists to put ourselves in a position to be at that table? Like, okay, we're gonna do this new procedure. How are they gonna move afterwards? What do we do?
I think it takes time, effort, knowledge. It takes building relationships with those people. All of these things take time, right? Like, yes, we got very lucky with this that like the lung transplant team was like, "Oh yes, awesome, on board." But I mean, I hear so many stories from clinicians across like the world really where it takes time to do these and I think just remembering that aspect of it. Like they might not be on board now, but just continue to show up, continue to showcase your knowledge, continue to ask questions, right? Make it a collaborative process between the two of you. So then that way, or the team, so then that way they see the value of what you bring and you see the value in their perspective that they're also bringing to the table too.
Yeah.
But yeah, I think it just takes faith, diligence, and knowledge, you know?
So three things I need more of for sure.
because we're talking about a lot of interdisciplinary collaboration and having like a seat at the table, did you guys specifically chat with like the nursing and the surgeons to all have like the same spiel of precautions for the patient so that the patient wasn't hearing a whole bunch of different things, or like maybe one surgeon was saying like part of it and then didn't mention the other things, or like nursing still mentioned like certain precautions or something like that? Like, did you have like something printed out for them to like chat about, or did you just like have some training? Like, how did that go?
We did a little bit of train. So we talked to the surgeons first because top-down approach, at least in this case, a top-down approach works, right? Just because the surgeon is the one who's dictating the precautions because he's the one doing the surgery and he's going to care the most about the outcome. Or she. In this case, it was a he, but I realized that two surgeons can be she's too.
Gotta be inclusive.
Um, but it started with them, and then we did roll out education to the physical therapy team specifically, and occupational therapy, I think, was also there. And then we had handouts that went out to nursing. I don't remember if did we do meetings with them too, Max?
Yeah, so you did one initial training, not for the ICU staff, but for the floor staff. And then I have done one follow-up training 2 years after initial implementation for all of those groups and our rehab hospital, which was seeing an increasing number of discharges to the rehab hospital as well.
But that's always a difficulty, actually, with implementing something new, right? And that there's full implementation science and more scientific approach ways that we could have gone about the implementation. I think that's one thing that we'd admit that we were lacking is the follow through, and especially when you work in a healthcare system where there's turnover, there's different people coming. It's expected that people are going to forget what the precautions are. They're going to revert back to external precautions that they're used to teaching. They're going to kind of get used to it over time in however they teach it. And so you need some constant reattention and refocus on like, here's the way we want everybody to be doing it. And it's difficult in a healthcare system to know how frequently to do that, to have the time and resources to do that when you're talking about, so many different providers across different teams, across different units, even extending, to our inpatient rehab hospital. And past that, it's a difficult thing to maintain. So the implementation science aspect of it is interesting. And I think that's something that if, others wanted to replicate this study or implement these precautions into their lung transplant population, that should be something that's really carefully looked at and considered on the front end.
Yeah, and even with like, I know we had a ton of LMS trainings that I feel like everybody has to go through. And there's been like a few created, at least like during my residency, that I thought were really helpful on different like protocols and precautions. But I'm going to be honest, I probably remembered like 10% of them, especially if I wasn't working with that population all the time. So I just think about like float nurses, or like you said, like new nurses coming in, or maybe somebody who's training in the ICU. Like, um, yeah, if there's like any modules or anything that you guys had implemented with that, which it sounds like you did a lot of training.
Yeah, I think we addressed the problem with training, and then we had patient-specific handouts.
Oh,
And
okay.
after Deb left, I also had those handouts translated into a couple of different languages based on patient needs as they came through,
Oh,
which
wow.
one of the cool features for us is we have an embedded therapist on the lung transplant committee. So I got a heads up before transplant surgery. Oh, someone who speaks only Spanish, reads only Spanish is coming our way. I can start that interpretation process, that translation process now, and have it fully approved before they get to the hospital, which was really helpful from a patient perspective. But yes, there is still that odd situation where an APC comes in for discharge and says, now remember, you've got that 4.5 pound weightlifting restriction that they pull out of who knows what
Hmm.
thin air and gives to the patient with no evidence or support in our protocol. So it takes a lot of time and attention, and it's ongoing for sure.
Okay. And I do have one more question, then Blaze, I'll let you riff a little bit if you want. I'm wondering, are your PTs stationed in one ICU, or like, are you guys kind of all over the place? Do you transition month to month? Or because I feel like if they were stationed in like one spot, then it's a little bit easier maybe to like keep up the protocols. And if so, how is it going to the state? I know that's two questions in one, but
Yeah, we use a Teams-based model. So the team that handles most of our lung transplant patients, at least during their acute post-op phase, is the critical care team. They work in three of our ICUs, the cardiovascular ICU, which is a cardiology and surgical ICU, the surgical trauma ICU and the medical ICU. And then we also cover our cardiovascular floors, which includes all of our post-op pulmonary patients. So with that teams-based model, we could have the same team of physical therapists, if not the same PTs, following those patients all the way through from surgery through to discharge home. And if they were critically ill enough, we frequently see them in our medical ICU, which is our respiratory ICU, before as well. So if our patients were on 100% BiPAP or the classic high flow with non-rebreather over the top and hoping for all of the oxygen in the world to be delivered into those alveoli, then we could see them pre-acute post-op all the way through to discharge.
Oh, that's
I think
awesome.
that
Nice.
helps a lot having that team-based model. But I also think that one of the things that allowed Deb to get a really nice perspective on this whole thing and be able to develop such a comprehensive protocol, and Deb, you should speak to this too, is our residents don't just live in that team. Especially for our cardiopulmonary resident, she gets an experience across the entire continuum of care, including some outpatient pulmonary rehab, so she can really have that full perspective.
That was my favorite part in residency was seeing all of like the lung transplants before, during, and after. And same with like the heart transplants, because then you like, I don't know, it's like crazy seeing them come in on like 60 liters or something like for mobility and pulm rehab, and then they go to the hospital, get their lungs, and then you see them like a month or two later and they have no oxygen. I'm like, I didn't realize that's what your face looked like because I've only ever seen you with like a non-rebreather mask on. So yeah, I always found that honest, like shocking, but so exciting. And then they were like, I can breathe. Look at me. Like I have no oxygen on. It was amazing. So I don't know if you felt the same way, Deb, but that was like hands down one of my favorite parts.
No, I loved it. I think I actually got to see one patient. They went like MICU. Like I think I saw them in MICU before they got their lungs and CV when they got them. And then, I ended up like following up with them like pulmonary rehab. For me, it was actually crazy seeing people in pulmonary rehab because I had only ever like spent my career like doing acute care in ICU. And I
Mhm.
was just like, oh my God, y'all aren't wearing gowns. Like you can
Yeah.
move. You're functioning. Like this is crazy.
Or like, I don't know if you had
So
stairs in the pulmonary rehab, but the first time I saw somebody use the stairs without somebody like right there
like
hanging,
guarding
like,
them.
what
Yeah.
are you doing? Like, why is nobody next to you? It's like, we're
Yeah.
fine. But
No, it really, and honestly, it made me like stretch my brain a lot more because I was like, oh my goodness, what do I do besides like bed mobility, sit to stands and walking? Like, I gotta really like tap into my bag here a little bit. Hold on. But it was cool. Yeah.
And so with this study, what was the synergy like between like because I love hearing these clinical experiences. It makes it all the more worthwhile to do this sort of stuff and to go this extra mile for the patients. And when you're going through this study, what's the synergy like between the hospital system and the university? Can you tell me about that?
Yeah, so specifically at University of Utah, we have a really close relationship. We have our health system, but it's also embedded right in the middle of a large university. So we're lucky in many aspects. And, others that work in large academic medical centers, you would probably say the same thing, right? We have all the resources at our fingertips that we could ever want. It's just a matter of figuring out who to ask, where to ask, sometimes how much money it's going to cost, right?
Yeah.
Uh, but it's a very nice place to work and to be able to have those resources. So things like having our DPT program, a mile away from the hospital where our residents can, come by and do some teaching and labs with our residents. Having our VA healthcare system right down the street where residents can go because they have PT run cardiac rehab. That's where they do their outpatient cardiac rehab rotation. We have a children's hospital right here on campus where they get to go do that. So having that sort of infrastructure, it also lends really well to research. So part of the reason it took this project so long to finally come through the finish line with getting published in CPTJ is it took us a while to get funds and get the support we needed to do appropriate statistical analysis and get this in a place where it was appropriate for a peer-reviewed journal, right? As clinicians, it's not always very easy to do that. I mean, huge round of applause for all the clinicians out there that are doing research and publishing. It is an uphill battle the entire way. But one of the things that we're really lucky with here is those relationships with our academic programs as well. So we were able to bring on Dr. Maggie French, who's a research faculty member here, to help us with our study design, help us figure out exactly what variables we needed to pull out of the EMR, the electric medical, Epic system afterwards, and the analyses that we needed to do in order to appropriately statistically analyze the data that we had been collecting for those couple of years. So, I think from a clinician standpoint, it's easier to come up with the protocol and make it happen. But then you're like, okay, now how do I get the data and what do I do with it? So having that research faculty member able to come in and help us with that part is very, very helpful. And we are so grateful to have those collaborations.
What advice do you have for folks who it is a waiting game for them? Like you just said, one of the biggest challenges is you're just waiting on funding. What tips do you have?
Yeah, so funding can be difficult, depending on where you are. You might have avenues where you can get research, especially for quality improvement projects that aren't necessarily clinical trials or anything like that. You might have ways where you can get that for without fees, but there are a lot of mechanisms out there. You'd be surprised to get funds. So the mechanism that we ended up getting was a seed grant. So it was a faculty grant, and I am a faculty member at the DPT program, so I was eligible for it and got to bring in Maggie and Max and Deb as co investigators on this. But basically saying, we want to work with clinicians, we want to work with this kind of multidisciplinary team here in terms of some clinicians, some researchers, some faculty to bring this research to fruition. And here's the money that we need to be able to ask the data analysts to pull the data, to pay for somebody to do the statistics, to pay the publishing fees, the open access publishing fees, because that's not money that, as a clinician, you're going to have. So there are mechanisms out there, and I encourage people, even small ones. In the past, I've gotten grants for like $1,000, $2,000. Even something like that can be really helpful in pushing something forward. And then you might be able to beg some other researchers that have grant funding or your department, to help cover the rest if you get it most of the way there. But it requires you, being on the lookout for what resources are available to you, to just asking people above you, your mentors, everyone you meet, like, what resources should I be looking at that can help, bring this project to the finish line. And everybody in a large medical system like this, there's so many resources that most people don't even know about, right? So you just need to keep asking until you maybe find something that you qualify for.
And are you guys still collecting data for like this 1 year follow-up that I saw in the paper, or like going to be publishing anything further on this?
So the data collection for these publications was just for that initial cohort that came through. So just for the two patient populations, the pre-implementation and post-implementation groups, and no additional follow-up has come since then, partly because we exploded as a transplant program and we did not have the staff to be able to keep collecting the amount of data that we were collecting, especially in the 12-week and 6-month follow-ups that we had built in.
And the implementation has still been going well. Like, this is the protocol that y'all are using on all of your patients.
Yeah, at least on the inpatient side, these exercises are introduced to our patients. The way it's originally written and was implemented for the first year in that paper is I was directly supervising a lot of those patients as they came through. Deb was directly supervising a lot of those patients as they came through in the acute setting, as they completed that full exercise protocol. What we found is as we tripled the number of patients that we were seeing, it was not a sustainable practice. I was coming in on a lot of my days off in order to collect the data and complete this exercise protocol. So the thing that our team has kind of settled back to is we still teach all of these exercises, but we teach them almost as an HEP for a hospital exercise program. And the patients are responsible for completing a lot of those exercises independently, which we see pretty good implementation for. Most of our patients report completing those exercises at least 80% of the time
Oh,
during
wow.
my,
Okay.
little bit of check-ins with them. That's not real data, so don't cite that or anything.
Okay.
But
It's already
anecdotally,
been recorded. It's already been
ah,
recorded.
please.
It's
Oh.
already been it's already been recorded.
David can cut it
Thank
out.
you, David. No, David, don't.
Okay. Never mind.
But I mean, I think that's something that we can still rely on too, especially as patient needs grow and our hospital systems are a little bit slow to respond. Being able to call those patients back into being on their own team is a really powerful tool that I have appreciated being able to use to try and keep this project going too.
So that kind of answers a question I was about to have because you kind of become trailblazers whenever you're fighting back against this skepticism. It kind of like being iconoclast. Ask Rich. He said that to years ago at CSM. I've been trying to say that word ever since. Do you think that's like a I mean, it has to be a net positive if you're having folks saying, no, we've always done it this way, and this is what we find to be most appropriate. But then you can just pull from all these anecdotes from patient experiences. Like, did you present those to the other disciplines, even though you already said that we got really lucky and they were really behind you with a lot of this stuff?
Yeah, so I'll speak to that. I'm the person who sits in for our weekly lung transplant meetings, so I get to talk to the surgeons and physicians really regularly about all of the patients that come through our program. And yeah, there's really positive reviews about this as a protocol and as a set of precautions. Deb did an amazing job developing these and coordinating well with them. We really get net positive all around. Every once in a while, you'll get a new surgeon that comes into the system and has one bad outcome, and they have that little bit of recency bias where they're like, what are you teaching these people? Because I'm pretty sure this guy was, I don't know, trying to hog tie his prize pig out back and split open a sternum." And I said, That's not on me.
That's
That's
beyond
not
you.
what we teach."
That was not in our protocol or
Yeah.
precaution. So
But thank you for the feedback. I will add some pig education into my clamshell process now. Thank you.
Sounds fair. Oh my
I
God.
think like even outside of this protocol though, so I work in a different hospital system now, and we hired a lung transplant surgeon. And so I am extremely excited to actually get to work with this patient population again. And I look forward to trying to implement this and have a seat at the table to see if we can kind of make this happen for this patient demographic. So it'll be interesting to kind of go back and see if we're able to. And so kind of like you said, I am looking forward to being able to pull from this data from personal experience. But I think in general, addressing that question, even outside of this, is I think that I don't like it in the sense of like being a trailblazer and like saying that we can like do these things because like not in a way to like elevate myself, but just in a way to continue to serve our patients the best that we can, right? Like I think that that was really like where this came from. And even in my work that I do outside of this, right? Where like you're mobilizing, patients on ECMO, when you're mobilizing people that are really sick, when you are dealing with, kind of like you said earlier, Blaze, with, like asking those clinical questions of like, am I doing the best I can here? I think that drawing on these clinical experiences is really important. And then even what Haley said, like trying to make it so that clinicians can continue to ask these questions, provide research and data for the people who can put it into publications, that we can just continue to advance and grow as the medical profession continues to grow, right? Like patients, the access to medicine that they have now is so advanced and it's changing. And so much of what we are doing is so behind in the times in a lot of ways. So how can we continue to catch up with them so that we can give these patients the best quality of life and the best outcomes from a functional standpoint? Because survival isn't everything. But yeah.
I Deb, that was a great answer. And he just, I mean, really it galvanizes me because like having finished a residency, and I'm in one now, what kind of confidence do you have talking to these other folks? Saying like, hey, look at not again. I'm all for like we're elevating the patients. They come first. But what kind of confidence do you have now speaking with other professionals, having done the research, having gone through a residency?
Oh, I think that that was huge as a result of my residency, especially with this project. Like I spent so much time in the literature and so much time, with this patient population, both before and after that. I think that residency really grew my confidence in a lot of ways. It's something that I'm still working on, right? But I do think in general, like getting involved with something like this and spending time in the literature and spending time with your patients is a great way to build that confidence. And I do feel for the most part very comfortable. I also am not afraid to advocate for my patients. So I think when I keep them at the center, it's easy for me to be confident because I know that I want what's best for them. And so I'm not afraid to voice it when it comes to them.
Ladies and gentlemen, this is a real life superhero we're talking to right now.
And I think that a lot of these changes come from experiences one-on-one with our patients, right? We see a patient that's unable to return home or unable to return to a hobby or something because of restrictions that have been put in place on them. And it's our nature as physical therapists to think about like, could we do better? Do they need these? Is the small risk associated with liberating these precautions a little bit worth the decline in quality of life that is resultant, right? And we see that. And we had a really quirky nurse a few years ago who had come from another healthcare system. And when she learned that we were doing move in the tube instead of sternal precautions, it blew her mind. And she told me that her own mother had been really reliant on a walker. And after her own cardiac surgery, had been sent to a skilled nursing facility rather than home simply because they wouldn't let her use her walker at all. Then at the skilled nursing facility, she wasn't getting up and moving. She got a pressure wound. She got infected. She ended up dying. And this seems really extreme, but the way she put it, she was like, literally, sternal precautions killed my mom. Like, she would be alive if she didn't have these sternal precautions. And it makes me so happy that you guys have gotten to a point where your patients are allowed to do this and allowed to go home. And I'm like, wow, that's a very extreme story. I'm very sorry, but also like, yeah, like what we do does matter. It does, impact quality of life, but it can also, yeah, save lives in some instances, right? If we talk about people being able to return to a normal state of function where they want to live, where they have quality of life, where they're not at risk for infections and bed sores and things like that, it does matter. And those types of stories and experiences that we all have experienced with patients are what motivate us.
And it sounds kind of like, from what I'm gathering, I think we're all quite lucky in the healthcare systems that we're in because most everyone seems to be like-minded and also want more progressive mobility and puts patients first. Not saying other systems don't, they just may not think about it in the same way. But I'm thinking about like maybe a cardiopulmonary resident who was at a more progressive hospital or somebody who was at a more progressive hospital moving to somewhere that may not have those same protocols and it's just them and they're trying to like break into a better standard for their patients. What's some advice that you would give them? And I don't know if any of you guys have gone through this experience. It sounds like I said, all the hospitals I think that we're at are pretty good about this. But if there's somebody listening, they feel like they're the only one, what would you say to them? I know it's a
I
loaded
can't speak to
question.
this. I can't speak to this because I've only worked at Utah, which is great privilege. But I will say, if you are that person and you work in a tropical location, invite the three of us out for a grand rounds. We're happy to come present. We'll be there for you. I'll let someone else speak.
I mean, that is something that is a growing need. I've been hearing of more physical therapists being part of teams that can consult with hospitals, right? And we've seen this with like the core delirium, like A through F bundle type
Mhm.
implementation, right? Of getting teams of people actually going to consult with these multidisciplinary teams about how to best implement this. And early mobility has been included in that, right? We have physical therapists that are part of these consult teams and are going to places nationally and internationally to help educate on best practice. As a PT, it's hard to be a change maker, right? Sometimes you feel like the low guy on the clinical ladder where you can't make a difference, but you can, and sometimes it takes time. It's also hard if you're just new in the system, right? So it takes time to build those relationships, and sometimes, you have to keep in mind that you're playing a long game, not a short game in terms of the outcomes that you want. I think that residency is a great venue for that. We've had several of our residents, especially our acute care residents, go on to other healthcare systems, and there's always some degree of like they do things different. I mean, I don't care what hospital system you're going to. Like every hospital system does something a little bit different, right? And you're going to have that idea of like what I think is better or could be better, and how do you go about making that? So I think that we try to instill in our residents a sense of leadership and of knowledge about quality improvement and the importance of it, and how to kind of go about making changes. Something even just as small as we do now a didactic assignment where we have our residents come up with some ideas for quality improvement and kind of write out like how they would go about it if they were going to implement this in this healthcare system. So I think that can be a really important avenue for change.
I
I
think
think
also,
another thing,
oh, sorry, go ahead.
sorry, I was going to say, I think another thing to consider is like outcomes matter to surgeons, to the medical team, right? And so I think that, like, yes, take the time, build those relationships, have the knowledge be embedded, but just remember, like, outcomes will speak for themselves and somebody can be against you. But if you show, even if it just starts with like one patient, two patients, three patients, if you show your value and what you can bring to the table, they will respect that more than anything. So I think just remembering sometimes to start on that micro level, and just yeah, just showing what you can do. I think it really like speaks volumes and it helps get you to where they'll start to listen to you and start implementing stuff for you.
Yeah, I think that's so right because my mentors at WVU have just been doing such a great job, getting more liberative precautions after getting a median sternotomy and then seeing how much they love doing this sort of stuff, seeing how happy their patients become. And I've heard anecdotes that, some physicians, other professionals have started to buy into it because of that. It's this weird juxtaposition between like research and anecdotal experience
Mhm.
and which one wins out. And it doesn't have to be like that, but again, I'm the guy riffing with a red shirt, Hawaiian shirt.
Well, I was gonna mention the outcome measure as well, but also just like getting them to see the patients and be like, that's my patient and look at what they're doing right
Oh
now.
yeah.
So I really appreciated at that point on outcomes, Deb.
Oh
Um,
yeah.
yeah.
I
I
have been known to walk my patient by the surgeons
yeah.
on purpose so that they can see what is happening.
Be
Like
like,
they
Yeah.
this
got
is the
PT
guy.
today, okay? They're getting better.
Classic Deb move that I 100% stole is when is transplant rounds again? I'll see your patients 15 minutes before that.
Oh my
What's
gosh.
that? They weren't in the room? It's because we were doing laps. You didn't see us? So sorry.
I have started purposefully going in like once they're a few doors down, I'm like, we're gonna go in there and we're gonna walk
Mhm.
towards them.
Mhm.
And they're gonna see how we're doing today. Yeah. All right. So we're getting kind of towards the end. I have one more main question about this, and then Blaze and I have some rapid fire questions for you guys that are they're fun but also relevant. So just mentally prepare.
I
Um,
did
I
have
was
a question, Ashley. Would it be helpful for the podcast listeners if maybe Deb did like a 2-minute recap of what these two articles are, or do you do that already?
Yeah, you could totally do that. Some of our intros, like we talk a little bit about it, but having it from Deb herself, I think would be wonderful.
Oh man. Okay.
Yeah.
Like if you could summarize it in one paragraph, like both these papers, Deb, like
Yeah. So both of these, okay, actually, it's easier, I think, to split them up into two. But the first paper details the clamshell protocol, which was put into place specifically for patients after undergoing bilateral lung transplantation. It is the first paper to truly address or put out a protocol for what precautions can look like for this set of patients. Our second paper um, is the data that we got from that pilot study. We basically compared one cohort pre getting the protocol or pre getting the clamshell precautions implemented and post. And that data, while it is a small cohort and a pilot study, did show that this is safe and something that should start being and could start being implemented at the nationwide and international level for these patients.
Thank you for summing it up so well. That was great.
Almost like I've been spending years doing this.
For real. Okay, maybe we can get David to clip that at the beginning. So then we'll take out our little part and then it's by Deb herself. Amazing. And then my final question before we get to our rapid round, unless Blaze has something else. I was wondering a little bit about like the prehab of these patients, if you talked with like pulmonary rehab or like the pulmonary rehabs they were at, or like the patients that you knew were going to be coming in for a lung transplant. Did you have them do a specific protocol that was kind of similar to what they did afterwards, like the strength training protocol that you guys were doing? So then they're already kind of like, it's already like part of their routine.
I'll let Max speak to this because I think that he probably had more experience with this.
Yeah, I think from the pulmonary rehab side, for pre, given that we were already having some difficulty getting our post implementation for the protocol when I think it was most important, I have not been involved in the pre implementation of anything. So, whatever they have been doing is what they have continued to do. If I'm lucky enough to see these patients myself ahead of time, I
Mhm.
actually give them the week 2 exercises as is if they can tolerate it. I think the biggest barrier for a lot of these patients is they just don't have the activity tolerance for it. The huge increase in volume that we've seen recently has also come with a really big increase in complexity and severity of our patients pre-transplant. And there's a lot of them that just cannot tolerate doing 10 reps of anything. So it's really tough. And it usually means I start with this as an idea, and then I do a lot of modification and adjustment to exactly how my patient is presenting. But that's just good PT.
All right. Great. Thank you. Blaze, do you have anything you want to add before we get into our rapid fire questions? And if Haley, Deb, or Max, if you have anything else you want to chat about, feel free to also chime in.
Nah, I got nothing. I think we just got some really good answers.
Yeah. Yeah, you guys did great, like covering everything. Whenever we asked one question, you covered like six other questions that we had. So I really appreciated that. Y'all were very thorough. All right. So rapid fire questions. Blaze, you want me to start? And then we'll
You,
start your other one.
yeah, that works.
Okay,
Since
let's
there's three of us, are you going to be like addressing one of us at a time, or are we just going to shout our rapid fire answer all at the same time so you can't understand?
That's a great question. Thank you for clarifying that. Let's do so it in order on my screen, it's Haley, Deb, Max. So can we do that order? Does that work? Haley, Deb, Max. Okay.
We're all answering the question.
Yes, everyone gets it. You have to do it 10 seconds or less, otherwise we kick you out of the meeting.
Yeah.
No
Or
changing answers. Okay.
or unless you three have a hive mind that we do not know about.
Yes.
Yes.
All right. So first, in your opinion, what is the most underrated clinical outcome measure do you think everybody should be using? Could be in cardiopulm setting, could also be all across the board.
Freed frailty assessment for sure, especially in
Uh,
lung, pre-heart, any pre-transplant, but probably in our cardiac population in general.
All right, awesome.
I was going to say SPBB for the same reason
you're
because
my
it can be used for frailty as
you
well.
just instantly became my favorite because I've been doing that since my residency, and I can't say it fast because I'll go to SP like I can't SP. You know what I'm talking about. That's like oh
Tug and cog tug, adding that dual tasking in.
All right, great.
I love the cog.
Yeah.
That's a good one. We do not spend enough time evaluating people's cognition well enough, but
Especially for my LVAD patients, where post-op, I'm like, oh, no one checked to see if you were going to be able to do those connections. Oh,
low fro brain is real.
yeah.
I say with love.
Shout out to OTs for doing the most with that sort of stuff. We had a little lunchbox in my residency that had like the cables and everything, and they'd go and like train them how to hook it up. And then if they couldn't, they would let the surgeons know. And sometimes they listen, sometimes they don't, you never know.
all right. Rapid fire question two. What's one book that every PT should be reading or read?
Can I put two out there?
Go ahead.
Yes.
For every PT out there, especially critical care PTs, should read Every Deep Drawn Breath by
The
Wes.
best.
So good. But one that I just read while on vacation because I'm a nerd, it's called Ticker by Mimi Schwartz, and it is kind of a biography of some of the pioneering heart surgeons from Houston area. Ashley, I know you're down there. Deb.
Oh, I think that somebody recommended this to me at the last conference because they're like, "Oh, you're there. You should read this book."
Yes,
And I actually
very
have it on my
fascinating.
to-do list is to read that. It's in one of my to-do lists. I have a lot of books.
Yes. Mike Shoemaker recommended it to me actually at
That's
the
who did too.
conference. Yes, and
Yep.
loved it, and I've been telling everybody about it. So, if you're a cardiac nerd like we are, especially if you love LVADs and transplants and total artificial heart things, must read. Ticker by Mimi, what did I say? Schwartz? Mimi
Yeah.
Schwartz.
The Essentials of Cardiopulmonary Physical Therapy by Ellen Hilliges. No, I'm just kidding. I would highly recommend, I love the book When Breath Becomes Air by Paul Calanthi, I think is how you say his last name. But it's a really good book. It's, just talks about yeah, it's just a really good book. You should just read it.
Um, since Haley gave two excellent titles, I'm going to take this as a joke round and say anything that's like 1001 jokes that, because you got to have good fodder for when the patients are having a tough time. You got to have the dad jokes.
Is that where you get your jokes from, Max?
No, they
That's
just
so
come out of
I was
nowhere.
gonna say, I definitely thought that they were original.
Oh
He's
my
the king of
God.
puns. He has all the puns and jokes.
I got my stepdad that book for his birthday, and every time that he texts me without like fail, it is just one of those. Whether it has to do with what he's about to tell me or not, it's just one of the jokes.
Excellent.
It's great. All right, next question. So, if you guys are sitting down to write a manuscript, some research, studying for something, because you guys are all always doing so many things, what's your coffee, tea, drink of choice order?
Mm. I've got a good coffee shop here, Alpha Coffee, Big Cottonwood Canyon, that I love to go do some riding at. It's got great views of the mountains, at least the foothills.
Mhm.
Um, and my favorite drink there is called the Amazonian, and it's like honey and cinnamon and it must be coconut milk and espresso, and it is so good. It's just like the perfect amount of sweet.
That sounds so good.
I'm a chai latte girl. Specifically, my favorite chai ever is at Alchemy Coffee in Salt Lake City, and I get it every day when I am there, whenever I am there. But yeah, I'm a big chai girl. It makes me happy.
Preface, I've been accused of being a coffee snob. I drink something called a sprover, which is halfway between an espresso shot and a pour over, and it is delightful.
I'm gonna have to look that up and try to replicate it.
Don't. The rabbit hole is deep and fantastic, but I'll spare you. Don't do it.
Hey, I won't get any work done once I start going down that road, so we just won't even go there.
All right, next question. To the hopeful researcher, what advice do you have to them whenever they're, a little bit reluctant? I don't know if I could do this. What would you say to them?
It's a team sport.
Mhm.
Find the people that are going to help you, that are going to help mentor you, especially in healthcare. Like people don't publish alone, and you're not meant to. So there's lots of people out there that are willing to take you under their wing. You just got to find your way to them.
Okay, we might have a hive mind because that was also my advice is find somebody who can make you feel or support you. So then that way you realize that you can do it because you can. Maybe not on your own, probably not on your own, but with the right team, you absolutely can.
Yep, hive mind on this one. And specifically, I would say pick Haley and Deb. Fantastic team to surround yourselves with if you can.
Oh,
Snaps for that.
yes. All right. So, favorite place to hike in Utah? Like hands down, if you're there, you have to do it. Does not have to be near Salt Lake.
Ooh, too many.
I know.
That's the hardest question you've asked,
I'm
Ashley.
sorry. Saved it for last. Actually, Blaze has one more.
Oh,
I
I
personally, Little Cottonwood Canyon is a very special place for me. That's always my go-to. That's where I ski in the winter, and hiking there in the summer is pretty phenomenal. Wildflower season is incredible. Mount Superior is smack dab in the middle of the canyon. You can climb up the south side of it, which is over 3,000 vertical feet in like 2 miles. It is absolutely
Wow.
spectacular, but not for the faint of heart.
And not to do if you just hop off the plane with altitude.
No, yeah, I've been well known for sandbagging people and taking them on really hard hikes at high elevation, and I should know better as a cardiopulm PT than to take a girl from Atlanta straight to 11,000 feet.
Just bring some of that like canned oxygen and you'll be fine. You know what I'm talking about?
Lots of evidence to support
Yeah.
that.
Okay.
Guys, maybe this is how we can change practice. Okay. Let somebody put out a paper. Let's do it.
Like the quality of canned oxygen doesn't not work on one control subject, and that was Deb.
I think Lake Blanche is my favorite, but
Um,
it's all great.
That's in Big Cottonwood Canyon.
If you go one more canyon over to Mill Creek Canyon, that's my neighborhood canyon. Right at the top of that, at Big Water Trailhead, there's a fantastic loop that if you park in the lower lot, you can make a trail half out of it, where you go up through the Desolation Lake Trail across Wasatch Crest, where you can look to your right and see into Park City, and look to your left and see into Salt Lake City.
Oh,
You go all the way
wow.
along the spine of the Wasatch Mountains and then drop down the Great Western Trail. And it's just this one big, beautiful loop with fantastic foliage and animals, and usually a moose or two that you spook or they spook you. Excellent.
I was up there a few weeks ago and I saw a whole family of moose, so we had to hike our bikes way around the trail to get away from this mama moose and her babies.
What are baby moose called?
Mooselet. I don't know.
Mooselets?
Mooselets. I like it. If that's not real, it's real. So
I think it's a calf, but petition for mooselet instead.
You should put a poll underneath our podcast and be like, is Mooselet a baby moose? So yes or no, and that will be established.
I think it's
Right.
a good engagement.
Yeah, I think
Oh,
so
yeah.
too. Wow, I wish we would have had more time in Salt Lake or like just Utah in general whenever we had the conference. Those would have all been so cool to do. But we still got
Yeah.
to do a cool conference hike.
Oh,
So
yeah.
that was gorgeous what you guys took us on. All right.
All right. I got two questions. I think one of my things is not writing one of them out to just surprise Ashley every single time we do it.
Yep.
So it's starting to get to the holiday season. We all like to get cozied up and put our blankets on. And if you were to light a candle to just set the mood, snuggle up, what are you picking?
My candles are definitely all like forest based
Hmm.
scents. I'm not talking Christmas tree, but like, some nice something that would smell like the forest.
Cedar balsam.
Cedar
It smells
balsam.
like the forest, and it's
Yep.
my favorite, and I will do it all year round, and I don't care.
I'm going to stretch the definition of candle to wood fire. Ta-da.
Oh,
Uh,
that's nice.
Big candle.
Love a good
And delish.
bonfire. I've been getting and it might be because it's my favorite cookie, but the snickerdoodle candles from Bath and Body Works. I'll just fall asleep right now thinking about
It
it.
just makes me want to eat snickerdoodles, though.
No
Hey.
bad thing for Deb.
So you have to make snickerdoodles while you burn it.
Hmm. And then it just becomes an even bigger problem for yourself because the more you burn it, the more snickerdoodles you have, and then you run out of space. And yeah,
Just exercise for 150 minutes a week. It'll be fine.
Exactly.
there's probably how about this? If it can affect your heart, there's an ACSM guideline about it. Yeah, snickerdoodle consumption, 50 minutes. I mean, 30 minutes, 5 to 7 days a week at 40% max heart rate. Who knows? Okay, final question. For me, it's the most important of the entire podcast, as they always are. Amongst you, each, how many Hawaiian shirts do you own yourself?
Uh, I don't have any proper
Oh,
Hawaiian shirts, but I just got a couple for my husband because we just went to this big event in Hawaii. So, like, I just told Blaze and Max before the podcast started, Ryan Spooner, great brand, local
mhm.
Hawaiian brand, makes high quality product. If you're looking for, as I called it, not tacky Hawaiian shirts, apparently offensive.
I feel like that could be like a tagline for the brand. Maybe
Yeah.
we could get a sponsor.
That's what I've been saying. What if we got a random sponsor from
And it would
Paradise
wear
Found?
the Hawaiian shirt, like
Yeah.
some sort of Hawaiian shirt sponsor. Nothing to do with
Nothing.
cardio poem.
Nothing cardiac or pulmonary related. Nothing.
What if they did make one that was, though? Be kind of cool.
It had
Just
little
like a but.
hearts on it, but it's the middle part's a heart, and then it's like flowers, or middle part's the lungs and the flowers.
We're also really big on our cardiopulmonary pun shirts around here.
Hmm.
We
Mm.
teach, and all three of us teach together every year. We always wear punny shirts. So I've got one that says "Quit fibbing," and it's got on it.
I have no Hawaiian shirts. My husband has no Hawaiian shirts. So I
But
think
how about your punny shirts? What are your punny
I
shirts?
do have some good punny shirts. I
That
have a
counts.
don't hate, ventilate, and then I have one that's not for the kids. So PG-13 or rated R from here on out, but it's a pleural effusion. It's a picture of it. And then there's a little chest tube going in and said, I'd tap that. And I think it's
I don't
great.
think that's rated R yet.
That's
You
so
need to
funny.
revisit your ratings.
I think we can keep that in. There were no curse
Yeah.
words.
Yeah.
Yeah, we're all adults here.
Yeah,
Yeah, come on.
exactly. I doubt a child will be stumbling upon this podcast, but if you are, I hope you learned something.
Blaze, I own 9 Hawaiian shirts, 2 from home.
Oh.
I will be wearing one to Strongwater Anaheim at CSM. See you in February.
You
Oh
almost
man.
beat Rich. Almost.
He had like
How many does
11.
Rich have?
He has
11.
11, I think. I have to go back and listen to it. But
I'll
yeah,
work harder.
or
Well,
11.
birthday is in July, so everybody get him some new
Yeah.
shirts so he
Yeah.
can be rich because that's very important.
Yes.
But not tacky ones.
No.
And no tacky ones.
So out of my catalog is what I'm hearing right now. We're tapping out of that. And I just want to say before we end things, it, Haley, I have missed you so much since September. I
Miss
I
you.
rem I'll tell you this. I was frying out, and this is for everyone who is there to remember. I was frying out because I'd already spent like $100 already on Ubers from that whole thing. And Haley, sweet saint that she is, was like, "Oh, I'll drive you down, no big deal." Oh my goodness. So is the next conference in Pittsburgh?
Don't forget, we put Connie in the trunk to
We
get to
did put
put you
Connie in
in
the
my
trunk.
car.
Yes. Yeah.
Wow.
I offered. Connie insisted that she go in the trunk.
For
But
people listening, Haley has a hatchback. So it's not like, you know what I mean? It's not a little like Toyota Camry trunk,
Yeah.
yeah,
okay?
we did.
Kidnapping vibe.
Be in the
Yeah,
trunk.
we weren't like the cardio pump mob bosses throwing someone in our trunk and all that sort of stuff. But I think is next year's meeting in Pittsburgh.
Mhm.
It is.
I'm making it my mission. If you go, Haley, you're not spending a dime on an Uber, not a dime.
Hey, well, what kind of car do you have? I'll be in your trunk.
Rav4,
Woo, there we go. I can fit.
Rav4 in
The
it.
trunk.
If I had to do a rickshaw thing, like, and I carry you in the back, and then
Oh,
I carry it myself, I'll do it. And we can put Connie in there too to make
yeah.
up for this year.
This
Yes,
is all
exactly.
documented, so you have to do that, please.
Oh Lord, I'm nervous already.
All right. Well, I just want to thank you guys so much for coming on this podcast. I know that y'all are so busy and doing so many amazing things out there. So just taking the time to do this really means a lot to us,
Yes, thank
especially
you.
on such like an important topic that doesn't have a lot of research. So I'm very excited to get this out to our listeners, especially those who maybe haven't been able to sit down and read this. So at least they get like some tidbits and then maybe makes them really excited to read it. So again, thank you so much. We've really enjoyed having y'all.
Yeah, and thank you to, the Cardiopulmonary Physical Therapy Journal for working with us through the editorial process as novice researchers. That process is probably as laborious for them as it is for us, I'm sure. So, big thanks to them and all the reviewers that put in the time to make such great research and great output for this journal. I think it's, wonderful that our specialty area has a journal like this where we can publish things that are, really meaningful for us and really get the word out there. So thanks to the journal.
Agreed. And
Abs-
thank you for having us.
Yeah, thanks for being amazing podcast hosts. I'm
Mhm.
excited
It
that you
was
guys are
fun.
kicking it back off again. This is great.
I'm
I was
so
nervous,
glad.
but this was so fun. You guys
Oh,
did great.
good. I'm
Oh,
so glad. I'm
thank
I'm
you.
honestly so new to this. Blaze has a little bit of experience, and you guys didn't get to meet Chris, who is literally a DJ radio show host for like 30 years, and he's also our other co-host. But he has a little one and also has been working a lot, so he wasn't able to make it to any of the interviews this week, but you'll hear him on some of the others, and like they're amazing. So he got to meet Taylor Swift apparently on one of his podcasts. or not podcast, radio show host things. But yeah, so thank you guys for going along with us, especially as me being a new podcaster. And then Blaze, I know you're semi-new, but you seem professional. So
Yeah.
Your mic
Yeah.
setup and everything.
Yeah, this yeah.
yeah, I have a mic. My mic doesn't work, so but I have it, and so it's something. I
If
did
I was you,
for
I
like
would have like still spoken to it.
I
Like
should have. I should have just like been like this the whole time.
make it till you make it. My mic also would not work if I have one. I already know. Technology repels me.
I
So
have tried so many different ways to get this thing to work and click like different sound systems in my computer. I don't even know what I'm doing. And every time that I do it, I can't hear me or I can't hear you guys. And so I'm just like, I'm just gonna have it here so I feel official. It was like $20 off of Amazon because I'm like, wasn't looking to spend a lot. So that's probably why it doesn't work, but it does light up like a rainbow. So that's kind of cool. Anyways, I know that you guys have a lot going on and probably need to hop off, but thank you so much again. Like,
Thank you.
seriously,
Thank you.
really appreciate it.
All right, good chatting with you both.
yeah. Happy
Yeah.
Thanksgiving next week, guys.
Yeah,
Yeah.
Indeed.
happy
Happy
Thanksgiving.
Thanksgiving.
All right,
Bye.
have a good one. All right. Thank you, everyone, for listening to the podcast today. In regards to today's reviewed research, our guests left us with a myriad of clinical pearls about lung transplant treatment. This research reminds us that meaningful practice change often starts with a simple clinical question and then the courage to challenge tradition. The Clamshell Protocol emerged from a resident's curiosity, grew through interdisciplinary collaboration, and ultimately became a model of what a learning health system looks like in real life. Clinicians observing a problem, researchers helping analyze it, and the findings flowing directly back into improved patient care. We also explore how vital it is to build partnerships between frontline therapists and the academic faculty who can support analysis, interpretation, and dissemination of our research. So to Deborah, Haley, and Max, thank you for pushing the boundaries of what's possible in transplant rehab. And to all of our listeners, keep asking questions, keep seeking evidence, and keep building bridges between clinical practice and research. Until next time, stay curious, stay collaborative, and keep moving the profession forward.